introduce endoscopy for the beginners, how do you report? As Dr. Shobna has said that and standardized endoscopy reporting is one which can be understood by anyone across the world. But for the residents, it is very important that they must know the basics of the common lesions, how to interpret that, what are the common causes, and I'll touch upon some of the commonly used gradings. I will not go into their interpretation or implications of those gradings, and I'll be restricting myself to white light endoscopy only, because in one of the subsequent sessions we have optical enhancement, and let's see that how far I go, because the topic is huge, and if I stress upon some of the points in between, it may get rather too long. Now, the learning objectives of this talk would be, what are the common definitions used in endoscopic reporting? For example, is there a difference between ulcer and an erosion? What are the common vascular lesions encountered? How do you report malignancy? How do you report inflammation? And some of the common gradings, as I said. And if time permits, I'll talk about inflammatory bowel disease reporting and the endoscopy of tuberculosis with relation to inflammatory bowel disease. So the foremost thing in endoscopic reporting is the descriptive part of it. It should start with location. Where exactly are you finding the lesion? For example, in the esophagus, it has to be how many centimeters from the incisors. And then, for example, for Barrett's esophagus, we look at how many centimeters from the Z line, the squamocolumnar junction. So there has to be a point of reference from which the distance is measured or reported. Then in esophagus, we can also look at the peristaltic activity. We generally don't look at it, but it is time that we started looking for it. And it has been commented upon in the literature 30, 40 years ago, but it will be worthwhile that whenever you do endoscopy, whatever lesions in emergency or otherwise, look at the peristaltic activity. There are criteria, the number of peristaltic waves in a minute, which can suggest a motility disorder, but with the advent of manometry, you will not rely on that. But still, in a patient with obstruction, for example, obstruction at lower end, is it a malignant one or just a functional achalasia cardia? Look at the peristaltic activity. Then you look at the diameter of the esophagus. Is it dilated or is it normal? Now, we generally don't look at it, but it is, I think if you start looking at it, you will see that the diameter of esophagus will vary in motility disorders, in patients with achalasia, in patients with strictures, peptic strictures, or other strictures. Then in stomach, you report it with reference to, is the lesion along the lesser curvature or the greater curvature? Is it in the fundus, body, or antrum? And particularly in relation to the incisura, because that is a very clearly defined mark, and a lot of lesions will occur around that area. Pyloric opening is well defined, and same as gastroesophageal junction. So gastric lesions are reported in that context. And something very important akin to the motility of the esophagus, the distensibility of the stomach. Again, something not reported widely. This is something simple to see, inflate air and see is the stomach distensible or not. In patients with infiltrative lesions, particularly carcinoma, the distensibility of that particular segment will be reduced. Now, this is an example of an ulcer at incisura. So it will be reported as an ulcerated lesion at the prepyloric area along lesser curvature. You look at the diameter 2 centimeters, ulcerated lesion with a clean base with pinpoint bleeding vessels. and the margins are smooth. This will be important to define all the parameters of this ulcerated lesion, especially when you are going to follow up this particular patient at 6 weeks, 8 weeks after PPIs to see what is the change in size, dimension, or other characteristics. Similarly, for duodenum, you have duodenum is a small part. You generally look at the first part and the second part only. Rarely go beyond second part. So in the bulb, duodenal bulb, you look at the anterior wall, the posterior wall, and the apex. For everyone, I would say that those who have access to a simulation model, it is easier to look at the anterior posterior wall. Otherwise, for every endoscopist, it is important that each one of you will do this exercise of putting in a scope and looking at where in the left lateral position, when the endoscopic light is towards the anterior wall, towards the abdominal wall in a endoscopy suite with lights off. So that is the anterior wall of the stomach, anterior wall of the duodenum, apex. So this exercise should be done by everyone I wouldn't say 3 o'clock, 6 o'clock, 9 o'clock, or 12 o'clock. It has to be, interpreted and identified by each one himself or herself. Then in the second part of the duodenum, you look at the folds, the approximate number of folds in a view, the height, the number, and the lesions. Now, in this particular endoscopic picture, this is obviously second part of the duodenum. So the lesion is in the second part of the duodenum, the medial wall, which you identify by the presence of the papilla below that. Polypoidal mass. Now this mass is a mass lesion which is polypoidal. You estimate the size. Now in this particular view, you cannot estimate the upper limit, but you look at the lower margin, upper margin, and give the approximate size. Now, how do you measure size of different lesions endoscopically? It is approximation, or more definitively, you use a biopsy forceps, an opened up biopsy forceps, which can be 5 millimeters or 7 millimeters. So you estimate the size by an opened biopsy forceps but as you go by, you give a overall impression, and which is generally more or less correct. And again, distensibility of the duodenum. So these are the very basic things while reporting lesions. In colorectum, you'll define whether the lesion is in the rectum, sigmoid, descending colon, transverse colon, ascending colon, or in the cecum. Then define the ileocecal valve. Have you gone till that level? Have you gone across the ileum, across the valve into the ileum? And in colon, you don't look at the distance from the anal verge, except in the rectum and sigmoid, because beyond that it is fallacious. Because the scope the colon can sleeve over the endoscope, and the distance is not actual measurement of the distance. For the same reason, when you have in distended colon with air, the distance will appear to be much larger. So you don't measure distance in centimeters except for in the esophagus. Now, in this particular case, it is a lesion in the sigmoid. This is the sigmoid, this is the rectum, rectosigmoid junction. So define the size of the lesion, 1 centimeter smooth elevated lesion without any ulceration, and again normal capacity or normal distensibility. So this is white light and reporting, and depending upon the need for narrowband imaging or other optical enhancement, you define the lesion more closely. Now, some of the very basic concepts: erosions versus ulcers. And erosion is a purely mucosal defect. Ulcer is a mucosal and submucosal defect, which can be even deeper than that. A fissure, we hardly ever report, but some of the patients with inflammatory bowel disease can have fissures also. Fissure is long, linear break in the mucosa, which is going beyond the mucosa into the submucosa also. So in contrast to the erosion, which is only in the mucosa, ulcer goes beyond the submucosa up to submucosa or beyond, and fissure will also go across mucosa but is linear and sharp. Now, here's an example of pre-pyloric lesions, a patient of non-steroidal anti-inflammatory intake. This is an ulcer, this is an erosion. Now, how do you say so? This is the reporting. So, erosion is superficial, ulcer is deep. You cannot say on this particular endoscopic view. Now, as I said, erosion is mucosal and ulceration is submucosa or beyond. Now, some examples, how do erosions look? This is an example of erosion in the antrum. Now, these are also erosions. Superficial, lean, geographical space, shape, stellate. These are also erosions. One can argue that they can be classified as superficial ulcers. Yes, but the terminology, as I said, there's no clear definition of superficial or deep ulcers. Ulcers are classically beyond mucosa. So these erosions will be common for non-steroidal anti-inflammatory agents, patients on ventilator, patients with stress bleed. So these will be classified as erosions only, not as ulcers. Again, some examples of linear erosions like a gave pattern in the antrum or even in the fundus. Again, all these are stress-related erosions. Now, what is an aphthous ulcer? Aphthous ulcer is an ulcer, whitish base with a surrounding halo. There are multiple ulcers. This one is slightly linear. This one is again longer. So the shape may vary, but the basic point is a surrounding halo. This is classical for Crohn's disease, but can also occur in other conditions, infections, as well as after non-steroidal anti-inflammatory agents. Now, this was an example of a gastric ulcer, which was benign. This is an example of a gastric ulcer, which is malignant. A malignant ulcer is one of the varieties is everted margins. It can be flat also, it can be depressed also, but classically everted margins, whereas the margins here are smooth and regular. Now, colonic ulcers, stellate ulcer, and deep ulcer. So you define the shape of the ulcer, the size of the ulcer, and you cannot say that it is deep in that sense that you are measuring the size of the depth or the depth. But you can see that the mucosa was somewhere here. This area, whole area is ulcerated, shallow, and then here is a deep excavation, which would be by common understanding going beyond the mucosa, beyond the submucosa even, and radiologically this will appear as a deep ulcer, stud-like ulcer, if you do a barium contrast study. So you define the depth of the ulcer to an approximate level. Now, ulcers can be in the form, apart from the description of the ulcer, you define the surrounding area. There is hyperemia here. Here, the same patient with CMV colitis, there are multiple erosions or reddish spots, hyperemia. Then these ulcers were stellate or rounded, and here is a longish serpentine ulcer. So you define the exact lesion rather than saying multiple ulcers seen in the colon. So the description should be full. How many ulcers? Approximately, adjoining areas, distant lesion, skip areas. So all the findings have to be reported. Now, in specific areas like at the gastroesophageal junction, if there's an ulcer, you have to define whether it is above the Z line. This is above the squamocolumnar junction, so above the Z line. This is an example of ulcers, post-EVL ulcers. So you define that this ulcer is in the context of variceal band ligation. So these descriptions have to be complete to make the other person understand. Now, ischemic colitis is an uncommon entity. The ulcer may be large, may be stellate, may be associated with hyperemia, may be associated with narrowing. So colonic ulceration in a patient with GI bleeding, again, will have different connotation as compared to colonic ulcers without bleeding. Elderly patient, you with this lesion rectal bleeding, a patient of hypertension, ischemic heart disease, you find large geographical ulcers in the sigmoid or at the splenic fracture, your first diagnosis will be ischemic colitis. Then vascular lesions are quite common, but their terminology is even somewhat more difficult to, you know, say that what is angiodysplasia, what is AV malformation, what is angioectasia. These are the three common terms used. Now, all the terms are similar. Vascular lesion, this is a frond-like vascular lesion or mushroom-like vascular lesion. Here you have the vessels coming out, so classically described for angiodysplasia. So you describe this lesion as a vascular lesion which is rounded with suggestion of vessel proliferating and going into the periphery up to a distance of about 2 centimeters from the source or from the central point. So the size, the shape, and the location of this vascular lesion, whether actively bleeding or not. Now, capsule endoscopy can also pick up such lesions. This is an example of the frond-like lesion in the small bowel. And part of the vascular lesions is portal hypertensive gastropathy, which we all know. The classical is the mosaic pattern. And this may be associated with red marks or cherry red spots. The lesions can be seen all over the stomach, whether in the antrum, towards the antrum in a stellate fashion, classical, this is the classical pattern where there is orientation towards the pylorus, or it may be a mosaic pattern circumferentially in the antrum with reddish or hemorrhagic spots. Diluphys lesion is an uncommon lesion, classically described as a vessel seen in isolation without an ulcer. Now, this particular patient had this vessel which was ligated, so this ulcer is following the band ligation. So 3 days after that, there was some mucosal ischemia. So a single vessel protruding out of the mucosa without an ulceration. If at all ulcer is there, it is just like a small halo around it. So diluphys lesions can be there in any part of the bowel, stomach, esophagus, or colon, or any part of the bowel. Mallory-Weiss tear is classically described below the G junction, going across the G junction actually. So 2/3 of it is generally below and 1/3 is above, or 2/3 or 3/4. So best seen on retroversion. You see a visible vessel here, the pigmented spot here in this ulcer, this linear lesion, generally one, but can be more than one. Then esophageal varices. Esophageal varices, we all, probably one of the commonest vascular lesions seen by all of the endoscopists is esophageal varices. They have been classified differently by different societies, different workers. One was, look at the size, 5 millimeter or more, depending upon the forceps, opened up forceps. The second is on the basis of something simple, small or large. Large is which meet in the lumen, small are which do not meet in the lumen. So this particular classification, the Japanese society says that you describe the varices about the extent from the G junction, how long up into the esophagus are the varices present. Are they straight like this, or are they slightly beaded like this, or are they tortuous? And then the size. So small straight varices are F1. Beaded varices which do not meet in the center, the lumen can still be seen, are F2. And if the lumen can get obliterated because of the varices without inflating air, then these are F3. So F3 varices will be generally tortuous, F2 may be beaded, but the size is the main thing, size and the straight or tortuous or beaded. Then the other features on the varices are the presence of stigmata of recent or impending bleeding, like the cherry red spot, veil marking, red veil marking, or hematocystic or hemocystic spot, that is varix upon varix. So these signs denote more likelihood of bleeding. Gastric varices are seen only on retroversion. The fundal gastric varices are seen only on retroversion. So every patient with a history of GI bleed, or where you are looking for evidence of portal hypertension on endoscopy, you must retrovert the scope. Retroversion is a part of endoscopic evaluation. Retroversion is not only done in the fundus, but can also be done in the second part of duodenum to look at, bring the scope back into the D1, the duodenal bulb, to look at the fornices of duodenal cap. Similarly, retroversion of the rectum scope in the sigmoid, retroverted back into the rectum, is the ideal examination for looking at internal hemorrhoids. So retroversion is an important part of all endoscopic procedures. Now we have the Serene's classification of gastric varices, GE or GOV1 along the lesser curvature, GOV or GE2 along the greater curvature. Then you have isolated gastric varices, GOV, isolated gastric IGV, and IGV2 is ectopic varices in the antrum or anywhere else you describe. So this is an example of varices along both the curvatures, lesser and right, greater curvature. These are the varices along the greater curvature, only isolated gastric varices. So you would describe them as bulbous, venous engorgements, if you have to describe, or you say bulbous gastric varices similar to F1, F2, F3, and whether they are conglomerate or separate from each other, and whether they are associated with any red spot, cherry red spot, or hemocystic spot. This is an example of an antral varix. So you will describe it as a antral vascular abnormality, dilated venous channel, serpentine or tortuous. This, in a patient of portal hypertension, this will be described as isolated or ectopic varices. Given as a single picture, this will have a number of differential diagnoses. It can be varices, it can be a submucosal mass lesion, or just a thickened fold, a part of the thickened gastropathy, thickened folds in hypertrophic gastropathy. So the differential diagnosis or the interpretation of the lesion is in the context of the patient, the symptomatology, and the rest of the physical findings. Now, ulcer bleed, whether it is a duodenal ulcer or a gastric ulcer. I'll briefly show these and then go to individuals. Whether it is a gastric ulcer or a duodenal ulcer, it does not matter. This classification of bleeding remains the same, depending upon the propensity to rebleed and likelihood of need for immediate intervention. So this is arterial bleed, a spurter, which is grade 1A. Forest, this is the Forest classification, Forest 1A. 1B is ooze. Then Forest 2 is a visible vessel. Forest 2B is with an adherent clot. Forest 2C with a blackish spot or pigmented spot. And Forest 3 is clean base. In any patient of ulcer bleed, you have to define the Forest class. Now, this is an example of spurter, Forest 1A. 1B will be active ooze. This is the visible vessel. This whole thing is the ulcer, and there is an active ooze going on. Here you have active ooze visible by smearing of the mucosa. Just a visible vessel without any ooze is Forest 2A, a deeply excavated ulcer in the duodenum with a visible vessel. This is an adherent clot which will be classified as Forest 2B. Now, if you remove the clot, you may change the classification, because if you see just a pigmented spot, it will be different. If you see a visible vessel, it will be different. So initial endoscopic appearance will be for S2B. If you wash the clot, are able to remove it, then it depends what do you see underneath that. It may be just a pigmented spot, which will be for S2C, an ulcer with a pigmented spot, an ulcer with a pigmented spot at the G junction seen from below. Then clean based ulcer. This is for S3. Now this is not a very good picture, but you can see most of the ulcer is clean base. This part one can discount because the view is not very good. So this would be the classification of an ulcer bleed. Now coming back to certain parts of anatomy, hiatus hernia. What is a hiatus hernia? Hiatus hernia is if you have, this is the diaphragmatic pinch. This is the squamo-columnar junction. This is the esophageal mucosa. This is the gastric mucosa. Now, the gastric mucosa is prolapsing across the diaphragm into the thorax. How do you identify this? The squamo-columnar junction is by the Z line. The salmon color mucosa of, there's a difference in the color of esophagus and the stomach. The number of folds are different, and the lower end of the esophagus has palisading vessels. Now, these are the palisading vessels in this inset, palisading vessels at the lower end of esophagus towards the gastroesophageal junction. So, folds and the palisading vessels. This will define the Z line, which can be very clearly seen in most of the patients. Something like this is easy to identify that the gastric mucosa is prolapsing. This is a clear-cut case of hiatus hernia with a lax gastroesophageal junction. But more often, you are identifying this hiatus hernia by the Z line, and these are the gastric folds. This is the area of the diaphragmatic pinch. This is also seen on retroversion, very well seen. This is the diaphragmatic pinch. This is the squamo-columnar junction. So this whole intervening part is the hiatus hernia, which is said to be, the hiatus hernia is classified if this distance is more than 2 centimeters. On retroversion, if you see this parallel defect, this is due to paraesophageal hernia. Now, this is what is Barrett's esophagus. You all know the gastric mucosa, the esophageal mucosa, the Z line. So the diaphragmatic pinch, the gastric folds, and the gastric mucosa. So different varieties, I'll come to it in the next few slides. So change in the distal esophageal epithelium to any length that can be recognized as columnar epithelium and confirmed by histology to have intestinal metaplasia. This was the original description of a ZAP classification. This is the squamo-columnar junction, clearly well-defined, straight, well-defined line. This is a wavy Z line with small, these tiny tongue-like elevations. But a Barrett's esophagus is when these are more than these tiny aberrations. So this can be a tongue-like projection, single or two or more than two, any number. So how do you define? On histology, you will see if you take a biopsy here, you will have the squamous epithelium and the columnar epithelium. So you look at it in the context of the diaphragmatic pinch. And this would be the Z line. So you estimate the Z line, and this distance is the C, the circular part, and this distance will be the maximal part. So just to get it better, here is the diaphragmatic pinch, here is a small hiatus hernia, and this is the gastroesophageal junction, and this is the gastric mucosa going up into the esophagus. So you measure distance from here, 0 centimeters. So this is the circular line. So this is C. 0 to 6 will be the C, and 0 to here 14 centimeter is the upper extent. So this will be the M, and this will be the C. So to get it better, you recognize the hiatus hernia look at the diaphragmatic pinch and identify the two lines. So this is the M, this is the C. So C1 and C6 will define the extent of the Barrett's esophagus. So this is 1 centimeter, this is 6 centimeter, C1, M6. So this is one way of describing Barrett's esophagus. So again, in a different representation. So this is the this is called the Prague classification. Here it is C1M2. So this is, if you have to describe Barrett's esophagus, it should be defined in this manner. Then reflux esophagitis, something very common. Any break in the mucosal surface in the esophagus is esophagitis, which may be just a break or maybe an ulceration or maybe necrosis. Now, this is the classification, Los Angeles classification of reflux esophagitis. This is the stomach, this is the esophagus, this is a break or an erosion. If it is less than 5 millimeter, this is grade A, more than 5 millimeter, grade B. If the two folds, adjoining folds, have a conjoint erosion, this is grade C. If the circumference involvement is more than 75%, this is grade D. So grade A, small tiny erosions less than 5 millimeter. Grade B, when the erosions are longer than 5 millimeters. Grade C, when the two adjoining erosions coalesce together, but the overall circumference involved is less than 75%. Grade D, when more than 75% of the circumference is involved. This is LA classification. So we must always define reflux esophagitis as per LA classification. Now, briefly about corrosive injury, classically causes necrosis of esophagus or stomach. It is defined as basically grade 1 is just hyperemia, grade 2 is ulceration, and grade 3 is necrosis. Ulceration is, if it is scattered, this is 2A. If it is confluent, this is 2B. If the necrosis is scattered, it is 3A. If it is confluent, this is 3B. So this is an example of esophagus. This is an example of stomach. Grade 2A, isolated ulcer in the stomach. This is confluent ulcerations covered with bile. Grade 2B, isolated necrosis 3A, and confluent necrosis 3B. So the confluent is, we are not looking at the circumferential involvement. Circumferential means any extent of circumference. It can be 2 centimeters, 4 centimeters. In esophagus, it is easy to identify. In stomach, you don't expect the whole circumference of the stomach to be involved. But more so in the antrum, you can say circumferential or patchy grade 3B injury. So to sum up, grade 1 is edema or hyperemia. Grade 2 is ulceration. If they are scattered, they are 2A. If they are deep and circumferential, 2B. Grade 3 is necrosis or charring. If it is scattered, 3A. If it is confluent or extensive, it is 3B. So I'll just take up esophagus and stomach in the next 10-15 minutes. When you start with esophageal, and pass the scope beyond the esophagus, into the esophagus, you have to look at the cricopharynx. This is an example of a corrosive patient who had scarring and adhesions in the cricopharynx. You look at the arytenoids, you look at the adhesions here. So this is classical for corrosives, but the point of my telling you this is that you look at the vocal cords. In patients with carcinoma esophagus, one of the vocal cords may be paralyzed because of involvement of the recurrent laryngeal nerve. So you just don't simply pass the scope beyond the cricopharynx into the esophagus. Spend half a minute in the cricopharynx, see all the parts, whether there are edematous, nodular. In patients with reflux esophagitis, you will have nodularity or hyperemia here. And then the vocal cord, something very, very important. Plummer-Vinson syndrome, the first lesion right at the cricopharynx, you see a web-like narrowing here. Now it is for any stricture for that matter, it is not only you describe the stricture, you have to dilate it and go down beyond the stricture to see, because for example, Plummer-Vinson syndrome is associated with carcinoma esophagus. So your endoscopic examination is not over simply by describing the first lesion. You have to complete the endoscopic examination. Peptic stricture associated with esophagitis, narrowing, it is telltale. Your straightaway diagnosis is peptic stricture. This is the point I was making, that you have an esophageal narrowing with ulceration here, but you do not know what is the rest of the esophagus. It may have more than one stricture. So all these examples are more than one stricture, a stricture at the upper end, but you may have long linear stricture or multiple strictures. So your examination should be more thorough, more complete. And except for patients with Candida esophagitis, all patients of dysphagia should have a barium swallow before you do endoscopy. You do not know what you are going to get. Beyond a Plummer-Vinson, you may have malignancy. Beyond a stricture, you may have multiple strictures. You may have more lesions. And if you push your scope blindly beyond the first stricture, you may damage or perforate the second stricture. So a barium swallow is mandatory in patients with dysphagia of all kinds. Then in patients with anastomotic stricture, can be eccentric. The lumen can be eccentric. You see, this is just an outpouching corresponding to this. So the lumen is here. So you must have a barium swallow to see where you are going. Radiation stricture, esophagitis can be just telangiectasias or ulcers and narrowing. Pill esophagitis is again, how important is the history? You just have a patient of odynophagia, you do endoscopy, find these lesions. You cannot interpret unless you have had the history taken of doxycycline or NSAIDs or aspirin or drugs which can cause pill esophagitis. Candida is, very evident, cheesy white material which may be patchy or more diffuse. Eosinophilic esophagitis, we often talk, do not see it much in India, but this is the feline esophagus. You see these corrugated appearances, or it may be associated with strictures. So this, you should know, food bolus getting stuck in a esophagus like this, the first possibility will be eosinophilic esophagitis. Now, infective esophagitis, there's no way to say that it is CMV or this is herpes or what it is. You have to take biopsies and send for samples. So any esophagitis other than peptic esophagitis or Candida esophagitis, you have to depend upon the cytology or histology or the doing further studies to look at the organisms. Esophageal diverticula clearly seen with full bolus. The importance is that sometimes you may pass the endoscope into the diverticulum if the diverticulum is very big. We had one such patient last week. The lumen was obscured because the diverticulum was full of food material. This is something, which of the two lumens is esophageal? The other one is diverticulum. Sometimes peptic esophagitis can also be associated with an outpouching. So this description has to be complete because a surgeon who is planning surgery has to know what a patient of peptic stricture or reflux esophagitis has. If you are going to do POEM, you must know what is the additional pathology in a patient of diverticulum, Zenker's diverticulum or whatever. What is Schatzki's ring? This is a normal ring-like, not a normal, it is a ring-like lesion at the gastroesophageal junction. Very well seen on barium swallow, and endoscopically you can distend it. The scope will go, but some patients may have dysphagia and then it needs to be broken. Intramural pseudodiverticulosis, again, something which unless you see, you will not identify. Multiple openings in the esophagus. This is a normal looking esophagus. It can be a part of the infective esophagitis or a part of NSAID or any other etiology of stricture. This was the lumen. These are multiple pseudodiverticular. So you have to describe that a patient with dilated esophagus with multiple outpouchings, if you clean it, you will find the lumen here, try to pass the guide wire. Why is it important to identify? Because then only you will be able to pass the guide wire unless you make an identification. Achalasia, as I said, would have a dilated esophagus, narrowing with food residue. Classical radiological finding. So ideally, every patient should have a barium swallow, will have a barium swallow. But on endoscopy also, lack of peristalsis, dilated esophagus, food residue, and narrowing at GE junction would be achalasia. Submucosal tumors, obvious is submucosal lesion with elevation of the mucosa, normal mucosal pattern, no ulceration. There's no way that you can endoscopically say what it is. You'll need an endoscopic ultrasound. Whether it is a leiomyoma or a GIST or a granular cell tumor, you'll need histology or a endoscopic ultrasound. Now, any lesion in the esophagus has to be biopsied. Any such lesion beyond what you have seen in reflux esophagitis. You do not know what it might be, just patch of esophagitis, drug-induced, or it may be a superficial carcinoma. Advanced carcinoma is easy to decipher. Most of our patients will be like that. So this you will describe as a polypoidal lesion in the, depending upon the site of upper third, middle third, lower third, so many centimeters from incisors or so many centimeters above. Obviously, you will not go across the growth here. So polypoidal, friable, with patches of ulceration, not negotiable, lower limit not clear, cannot be ascertained. So that will complete the examination, and obviously it will warrant a CT scan to know the extent of the lesion. Now, stomach is, you have to describe the lesion on the lesser curve, whether it is on the greater curve, whether it is in the fundus or antrum or pylorus. So, and a retroversion is a must. I described the benign ulcers, which may be small or large. So an ulcer right at the incisura, which is about centimeter long and half a centimeter wide, with margins merging with the rest of it, no visible vessel or no other lesion. This was a large ulcer in a non-steroidal anti-inflammatory agent induced ulceration and with gastric residue. So any patient with ulceration, you have to define whether the stomach is distending normally, whether there is any residue present or not. So presence of residue means that there would be associated gastric outlet obstruction, whether symptomatic or not. You can even pick up asymptomatic gastric outlet obstruction by the presence of residue. Now, in a patient with GI bleed, this residue may obscure your view of the fundus. So what you do, you turn the patient from left lateral to supine or even right lateral. You turn the patient 180 degrees. This fluid will shift to the other side or shift the other way, and at best you elevate the head end or change the direction of the fluid. So that can give you a clear view of the fundus. This may be needed in many of the patients with GI bleeding. Now, carcinoma stomach may have an ulcerated lesion with everted margins, a frankly everted margins, polypoidal lesion, or it may be a depressed lesion. So endoscopically, you cannot say is the malignancy early, cancer early, or advanced. That will depend upon narrowband imaging. Now here is an example of a large ulcerated lesion. So you'll describe it as distal body large ulcerated lesion with which is geographical with polypoidal lesions towards the edges of the ulcer at places, no ulceration, no bleeding, and reduced distensibility. So this will straight away give a meaning that this is most likely a malignant ulcer. Now, can you differentiate lymphoma from carcinoma? Classically, lymphoma still has distensibility maintained. So you should be able to inflate stomach in patients with lymphoma. Otherwise, the lesion may be same, large ulcers, more than one ulcers. If the ulceration spreads or extends onto the duodenum, the first part of the duodenum, it is more likely lymphoma than carcinoma. Carcinoma is restricted only to the stomach, whereas lymphoma can get across the pylorus into the first part of this duodenum. Maltoma, can you say on endoscopy that this is a maltoma? No, you have to have histology. Again, you see the normal distensibility, a punched out ulcer with surrounding mucosal abnormality. Gastroesophageal junction, unless you retrovert the scope, you are not going to pick up this. A patient of GI bleeding, unless you retrovert, you are going to miss, particularly along the lesser curvature, because the scope is along the lesser curvature, so you may miss it. So you have to turn the scope, rotate the scope the other side, and see all the circumference of the gastroesophageal junction from below. A classical lesion, heterotrophic pancreas with umbilication in the center. Submucosal lesion with umbilication, 1 centimeter umbilicated, elevated lesion with normal mucosal pattern. Neuroendocrine tumor, submucosal lesion, again 1 centimeter small submucosal lesion along the lesser curvature. Multiple small elevated lesions, polypoidal lesions. This can be polyposis, this can be hypertrophic gastritis, or in this case was metastasis from lung. Stromal tumors are classically submucosal and with this volcano size. This is the classic picture of a stromal tumor in the stomach, but not all patients may have this volcano-like appearance. Some of them may have just a smooth bulge. Again, identification will need, this will be a suggestion, this will be needing EUS. Now, a bit about chronic gastritis. This is the normal vascular pattern of the stomach. This is when you see the vessels, the mucosa is so thin that you can see the vessels, and there is discoloration of the stomach. So a patient with chronic atrophic gastritis in the fundus, there is vascular pattern which is visible, and here there is, pale mucosa. So in the fundus, you may have visible vessels. In the antrum, you may have a salt and pepper-like mucosa. You can visibly see that the mucosa is abnormal. The normal folds are not seen. The normal vessels, the normal mucosal appearance is not there. So this may happen in atrophic gastritis due to H. pylori or because of any other cause. Hypertrophic gastritis is easy to decipher. It may be Menetrius disease or ZDS or any other cause causing hypertrophic gastritis. Gastroduodenal Crohn's, again ulceration. No way to say that this is Crohn's disease, this is not tuberculosis, this is not some other ulcer, this is not malignancy. So such lesions have to be described as such, that at the incisura, there is a large ulcerated area with polypoidal lesions around that. There is no visible vessel, there is no bleeding, and the distensibility is, you cannot comment upon in this picture. But when you see an adjoining picture that the ulcer is deep, punched out along with this, so this will suggest you a diagnosis of Crohn's disease, but you will need a biopsy to say what it is. I think I'll just talk of duodenum and leave it at that for today. This was just a clean-based ulcer in the duodenum. Ulcers or erosions in the duodenum. Again, making the same point that one narrowing does not mean that this is the last narrowing. You have a narrowing at the pylorus, you went across, this is the duodenal bulb, but at apex there is another narrowing which was dilated, and you saw another narrowing here. So multiple web-like narrowings in a patient of non-steroidal anti-inflammatory drugs. So Don't leave your endoscopic examination at the first narrowing. Lastly, about celiac disease, you look at the first part of duodenum and the second part of the duodenum. First part may have nodular mucosa, second part of duodenum may have decreased folds, the height of the folds may be decreased, and then there are telltale features of scalloping. This is scalloping, that the mucosal folds are scalloped, they are not regular. The in between the folds, this is the mosaic pattern. This is actually a capsule endoscopy, but brings out the villi in the duodenum very well. Normal villi. So here you see the scalloping very well. And this picture shows you the mosaic pattern. Here the villi are blunt, same as this, and there is layering of the folds. Nodularity, all folds are destroyed and you have nodularity. So these are some of the examples of celiac disease. There's no way you can say that thickening of folds in a patient is because of this or that. So this was an example of eosinophilic duodenitis. You have to take biopsies. Duodenal Crohn's, again I said, you need histology. So I think I'll, Dr. Usha, finish here because, yes. We can take it up later. I'll come to the the key to a good endoscopy is observation. Anything abnormal reported has to be looked at. The mucosa, the extent, the associated lesions, and don't stop at one lesion. There may be 2 lesions in a patient, there may be 3 lesions in a patient. The examination must be systematic and thorough. There's no shortcut that this patient had pain in abdomen. I'm looking for an duodenal ulcer, so I'll just go into the second part of duodenum, look at it, and come out. Every patient, it won't take more than 5 minutes to do a complete thorough examination of esophagus, stomach, and duodenum. So don't stop, don't make a shortcut examination. I'll take enteral biopsies and come out. No. Every examination should be thorough and reported properly. Any abnormality, mucosal, vascular, structural, functional, like distensibility or peristalsis, has to be noted. The report has to be descriptive, and for conditions which have grading, the report has to be as per grading, so that anyone and everyone can understand that, and more so, if a patient has to be followed up, you can compare. And for necessary, wherever necessary, you have to have narrowband imaging, EUS, or histology to supplement your findings. But white light endoscopy remains the first examination, endoscopic examination anyone would carry anywhere in the world for any of the GI symptoms. So that was about the upper GI tract. Maybe we can have lower GI tract some other time. Thank you.
Before. And that brings me to one point, that what the mind does not know, the eye does not see. So besides these things, besides knowing the classification and all that, that comes a little later. But first is to appreciate everything in the endoscopy and say, this is normal, this is not abnormal. Can you just highlight a little bit about that?
Yes, I think you have very rightly said the crux of the thing, that anything abnormal has to, you have to have, as a gastroenterologist, endoscopy is a part and parcel of our training and our livelihood. And for the patient who undergoes an invasive procedure like endoscopy, this should not be taken lightly. This is an intervention by all means, and it has to be accounted for. So the examination should be complete, should be thorough, and any abnormality, very rightly said, normal, abnormal. So to certify anyone as normal means a lot to him. So very rightly said that that should be the message, that should be our understanding, and the students must appreciate this fact that an invasive procedure should be accounted for and should be worth it.
Yeah, there are a few questions on the chat. Can we just go through them, Usha?
Yes, go ahead, please.
So, one of the first question is that in a patient who has an ulcer, where should you take the biopsy from? The base of the ulcer, the center from the ulcer, or from the side of the ulcer?
Classically, you will take 4 to 6 biopsies from the edge of the ulcer. You can take a biopsy from the center of the ulcer as well, but classically from the edges of the ulcer, 4 to 6 biopsies.
Now, is there any reason for taking only the edge and not the base of the ulcer?
Because the base is going to be necrosed, and you may not get any, unless you are going deep, you are not likely to get any of the representative tissue. So quite often you have ulcer, even the edge is reported because the edge is not very clearly, sampled in a hurry. So you will have non-representative biopsies. The edge should be sampled, and for patients with, say, for example, Crohn's disease or tuberculosis, you can take repeated biopsies from the same site, 2, 3, 4 biopsies from the same site. That may get you to the submucosa also at times. But that is only for tuberculosis or Crohn's disease. For malignancy, I have seen in Japan, they were taking a single biopsy. I could not believe myself that for screening, surveillance, follow-up, they would take just one single biopsy from a lesion. So I questioned that. They said one biopsy is enough. But we know that previous literature had shown that adding biopsies, the number of biopsies increases the yield. But in Japan, every biopsy was under narrowband imaging. There was no white light endoscopy. They would start with white light, immediately convert to narrowband, and all malignancies were done under narrowband and sampling done under that. So they said only one biopsy is enough. So maybe if we might, graduate to narrowband imaging so routinely, we can get more specific biopsy taken.
I think that will be in the near future. And we have 2 sessions on narrowband imaging coming up. So I guess the students will get around to that. So one of the questions is from Sunil Bhatt. If a tumor is involving the GE junction with an extent 2 centimeters proximal into esophagus and more than 5 centimeter into the distal part, can we classify this as per the CWAT classification?
As per?
CWAT classification for gastric cancers.
Okay. So I purposely did not touch upon any of the classifications of gastric tumors or any tumors for that matter. I thought because polyps is, narrowband imaging is going to be discussed later. So I wouldn't comment on that.
Okay. How do you differentiate between a true and a pseudo diverticulum? This has come from Sumit Kumar Vagasia.
I believe it would be for esophagus.
For the true and the pseudo diverticuli.
Okay. See, pseudo diverticula in the esophagus are small, very tiny, and just appearing on endoscopy as pinholes. Rarely they are larger. In duodenum, in patients with non-steroidal anti-inflammatory drugs or opioid ingestion, you may have larger pseudodiverticuli. In patients with duodenal ulcer, we in the pre-PPI era, we used to have more advanced disease. We used to have gastric outlet obstruction due to ulcers. And there we used to have pseudodiverticula and the classical trifoliate deformity on barium swallow. So there could be a pseudodiverticulum in the stomach or in the duodenum, which could be large in patients with ulcer disease. In the duodenum, because of webs or because of NSAIDs in the esophagus classically because of strictures. Any etiology of strictures can have pseudodiverticula. The esophageal pseudodiverticula were linked at one time to Candida superinfection, but not widely accepted. But one theory is that true diverticula are larger. They can be pulsion or traction. What we classically see is, say, like patients with tuberculosis, mediastinal tuberculosis, there is a diverticulum present, which is uh, because of shrinkage or fibrosis of the lymph nodes, there is extra, the esophageal lumen gets expanded at that. More commonly, the epiphrenic diverticulum or the Zenker's diverticulum are the two classic true diverticula of the esophagus, and one at the upper end, one at the lower end. So there's not much, except that they are so obvious that you don't need to differentiate from pseudodiverticula.
Okay, there's one question from Preeti Gupta. When can we say that there is a deformed duodenal bulb?
Oh, yes. I had thought that I'll add a couple of pictures. See, duodenal bulb across, once you reach the pylorus, you inflate air. Ideally, you must give Buscopan, muscle relaxant. The duodenal bulb is classically bulb shaped and should be smooth, distending well. So if it is not smooth, does not distend well, then you suspect it to be deformed. Then it may have, one fornix obliterated, the second one obliterated, or multiple scars in the duodenal bulb because of healed ulcers. D1, D2 junction may not be at the 90-degree angle. It may be twisted. So all this will classify as deformity of the duodenal bulb.
Okay, so what is a large and what is a giant duodenal ulcer?
Large is more than 2 centimeters, giant is more than 5 centimeters.
Okay, so that's pretty straight. And okay. So again, that thing about superficial ulcer and erosion, somebody's asked, do we need to take a biopsy every time we find a lesion like that?
Erosions you don't biopsy. You need to take a biopsy only, say in the esophagus, you will take a biopsy if it is not classically peptic esophagitis, not classically drug-induced esophagitis, not classically corrosive. That means all will have a history of reflux esophagitis or NSAID or drug ingestion or corrosive ingestion. If you are suspecting in an immunocompromised patient, you have Candida. Candida can be diagnosed on brush cytology. For diagnosing CMV or herpes simplex or tuberculosis, you will need a biopsy. For ulcers in the stomach, if it is a benign ulcer, classically described as in the pictures, you don't need a biopsy. A non-healing gastric ulcer warrants a biopsy. So a non-healing ulcer is when there is no healing at 4 weeks. In the older days, we used to measure the size of the ulcer. Now, with strong PPIs, the ulcer should disappear or should heal significantly at 4 weeks. So it would not warrant a biopsy. Non-healing ulcer will warrant a biopsy.
Okay, so now Praveen Rao has a very nice question. What is the difference between a nodule and a polyp? So essentially, I think we're talking about sessile polyps. When will you call it a nodule?
Okay. See, nodule is, see, it is endoscopic description only. You can say that a lesion is submucosal if the mucosa is normal.
Yes.
So a stromal tumor or a neuroendocrine tumor, carcinoid, these are all submucosal and will appear as you will describe it as submucosal. A nodule means that it is separate from the mucosa or overriding the mucosa. Same is true for polyp also. So a nodule or a small sessile polyp will be a nodule. To put it in that terminology, small sessile polyp can be classified as a nodule also.
Okay.
But if you come to the duodenum, you have partial nodular transformation, nodular Brunner's gland hyperplasia. That carpet-like nodules, those lesions we describe as nodules.
Correct.
Whereas polyps will be stand-out lesions, sessile or pedunculate.
Okay. So again, there's a question about the Seattle Protocol. Do we still follow it, or it is the end of that protocol in Barrett's esophagus?
I think you are the best person to answer that.
No, I don't use the Seattle. And neither do 80% of the people who actually were taught how to use it. So it's a very cumbersome protocol. The pathologists also don't like it very much because you send them so many tubes. But yeah, at least we don't use it unless there's some abnormality that we're looking at. Okay, one of the questions is a very basic question. Are the terms duodenal papilla and ampulla synonymous? It's a very interesting question.
Yes, yes. It is like esophagus with an O and esophagus with an E.
So I take it they are synonymous.
Yes.
I enjoyed the question and answer session, Rakesh. There are a few questions on the colon, but I think since you've not spoken about colonoscopy and the classifications, we'll leave them aside for the time when you take the second lecture. So over to you, Anup.
There are no questions, I think. Usha, what is the program? What time? We have to close it.
We have gone beyond, but it looks like such a kind of teaching session does need 1.5 hours.
You are not audible.
Okay, just 1 second. I'll come. I think it was intended to be a 1 hour session, but looking at the residents' participation, I think it is necessary that we keep these sessions as 1.5 hours. So that's a learning point. And it is very heartening to see about 180 people had joined in, and we have another 20 people here. So about 200 people have benefited from this. And all these 200 people are very fortunate, I should say, for having Professor Kocher take this lecture. He has more than 40 years of experience as an endoscopist, and he's an astute endoscopist with a very keen sense of observation. So with this, I'm sure it would benefit the next generation of endoscopists in the country. So I think you all are very fortunate to have been here today and participated in this session. Thank you so much. Just as an announcement, next session will be the last Saturday of February between 3 and 4:30 p.m. It will be a PGI AIMS SGPGI e-Pathshala workshop. The second one is on tips and tricks for doing colonoscopy. We will share the program and the link with you. Thank you, everybody.
Thank you,
Dr. Shobna. Thank you.
Thank you, Usha. Thank you, Anup.
Thank you, Dr. Saraya. Thank you, Dr. Shobna. Thank you so much.